Good morning, good afternoon, and good evening, everyone, from wherever you're joining us, and welcome to today's webinar titled Partnering with Disease Registries, the Value and Impact for Real-World Evidence Generation, featuring experts who will present guidance on why strong connections with registry groups and stakeholder populations are important for generating relevant real-world evidence to advance treatments. I'd like to thank the sponsor of today's event, Evidera, part of PPD, for making it all possible. I'd also like to take this moment to introduce our speakers for today's session. Firstly, we have Dr. Javier Cid, Senior Research Scientist, Real-World Evidence within Data Analytics at Evidera. He has experience planning, implementing, and analyzing several drug and disease registries and databases, as well as developing and implementing signal detection for pharmacovigilance. The second speaker with us is Dr. Naila Justo, Executive Director of Real-World Evidence Integrated Solutions at Evidera. Naila has over 15 years of experience and is responsible for leading cross-functional teams focused on RWE generation and insights, especially the use and analysis of data sets such as clinical registries. Our third and final speaker is Dr. Delphine Saragusi, Executive Director of Real-World Evidence within Strategic and Scientific Affairs at Evidera. Delphine is a physician in public health and social medicine with 15 plus years of experience in epidemiology and pharmacoepidemiology. I am excited to welcome Naila to take it away.
Great. Thanks so much, Sydney. So welcome, everyone. If we move on one slide. Yes, I can move them. Now I remember. So this is what we have for today's agenda. We are going to start with some basic definitions so that we make sure that we're all aligned. And then we are going to talk about that crucial relationship of working with these clinical registries. Then we will go through some of the practicalities that are important to remember, and then we will go through particular cases in which the support that the registries need have to do with expansion or augmentation or improvements and so on. So without further ado, let's move on to the next slide. And here we are. So I wanted to start with a bit of a historical perspective of what we today call, and I know that the presentation speaks about disease registries, but we prefer the term clinical registries because it's the most overarching of them. And it's because these type of registries, I mean, there is nothing new under the sun, but this type of registries have been around for a while, but they have been evolving and they have been serving different type of purposes. So from the typical surveillance registries after the war, like the cancer registries or standing cohorts, and I mentioned the Framingham, but you know that there are plenty of those, to the quality registries that started being created in Sweden and the Nordic countries to monitor indicators of healthcare provision, then the more academic type of disease registries defined by a specific indication or specific disease. And well, the examples in HIV/AIDS in the 80s and 90s are one of the many. Then we see the proliferation of those international collaborations, like the networks of excellence of a specific disease that also gave room to what then would become known more as patient registries. And these patient registries actually did proliferate much more thanks to the heavy investment from the European Commission and the EPIA through budgeting instruments under Horizon 2020 or promoted by the IMI calls, and more importantly, starting being used in a more formalized way by the European Medicines Agency in pilots like the adaptive pathway. Then the creation of PRAC marks a bit of an inflection point, and we see the proliferation of the product registries that are more specific and narrowly defined and very well aligned with a very narrowly defined research question, but some of them also survived and expanded. And another inflection point probably is the creation of the initiative for patient registries by the EMA that landed after a lot of work and multi-stakeholder consultation, landed in the in 2021 in the creation of the directive on the guideline on registry-based studies. So these clinical registries that we are talking about, as we see, started in different ways and started with different purposes and so, but what we see is that they are converging, and that's why it's important to see that historical perspective, because it kind of shows us the direction of travel. And what we see is that in terms of purpose, we started with epidemiological surveillance or safety surveillance narrowly defined. We went into more general quality indicators that also evolved themselves. They started being about the process and the systems, and they ended up being in what we have in the third box, those patient-centric type of registries that expanded the purpose to include trial eligibility, capture of PROs, other types of clinical outcomes, and so on for patient-centric research. So what we see is that most of the registries are or are going toward a more multi-purpose, more overarching, more holistic approach. The data owners or controllers, they have different names, or custodians and so on, also have been diverse. In some cases, they are academic centers or networks of excellence, typically from clinicians. In other cases, governments or public sector agencies. Some of them, of course, are sponsored by the industry. And what we see is that whether they start as such or if they are moving towards, there is more and more this multi-stakeholder type of consortia involved in the registries. And of course, it's very important, and a little line that we had in the previous slide that had to do with the parallel evolution of the technology and the technology enabled capabilities, because once we started, and some registries are still there with a CRF-based manual data extraction at regular intervals, in some cases annual and so on. That's very laborious. Then evolved into the EDC automatic or EDC capture of the data in real time, to a more, but still manually, to a more fully automated capture from the structured fields, from EMRs or other systems, and the complementarity with the manual mining of or even AI mined of the free text fields. So nowadays what we see is that from the data capture all the way through the data use, there are technology-enabled solutions with this type of hybrid resolutions. So what are the key use cases? And clinical registries, like any source of real-world data, of course, can be used throughout the life cycle of a product. And we have heard extensively spoken about the uses. And this week with the workshop that the EMA hosted, we had a very good demonstration of how most of them have been accepted. But there is but one of the things that is important to remember is that the evaluation of the fitness for purpose is important in order to be in order to optimize the approach. So whilst, for instance, the clinical registries are perfect for the optimization of clinical trial design, the screening and acceleration of the recruitment of patients, and to generate evidence for genotyping or phenotyping or profiling of subpopulations and so on, they are less fit for studies that underpin commercial drivers because of the leadership interest. And we're talking about pipeline prioritization, competitor landscaping, and so on, for which perhaps more commoditized type of sources are better suited, like, I don't know, claims data and EMRs. And the same goes for the applications for regulatory submissions. I mean, lately, more and more, we see a formalization of the processes and procedures to be able to use them to generate pivotal evidence and primary and secondary indication, and more specifically for the creation of natural history or external control arms in the case of single-arm trials. But in terms of the uses for HTA and payers, we see that there is ever so extensive use of the clinical registries to generate evidence that underpins the negotiation and execution of performance-based risk-sharing agreements or early access schemes, early access programs, but perhaps they are less suited for the generation of evidence that is necessary to populate health economic models and so on at the moment of market access submissions, such as healthcare resource use and costs. And again, perhaps claims data is better for that. Long-term follow-up studies that start in clinical and then continue in pharmacovigilance, in commercial, and so on, are a perfect example of where an early engagement of a clinical registry can serve multi-purpose and multi-internal stakeholders. And last but not least, the most typical use that are the generation of confirmatory evidence for post-authorization marketing commitments, whether in safety or in efficacy. So I'm going to say a few words about two of the key components of working with a registry, and we could have a one-week seminar to go through each of the key components. So I will not bore you with that. I just want to highlight a couple of things, and Javier will highlight a couple of things about the other ones. So basically, in the way we work with clinical registries, we have three key components and two enablers. So the science, the data strategy, and the technology that enables the optimization of that strategy, and the stakeholder management and the leveraging of that expertise the registries bring. And then the regulatory aspects and project management and cons are the enablers. So let's look at the stakeholder management. And this is some of the most important key takeaways that I want you to take home with you. So the clinical registries are not a typical data provider. They are the embodiment of the entire community that gave birth to them. And that means a lot, because one has to remember that these are people that can be engaged and that can contribute so much more. They bring expertise. They are the ones that know most about these patients, about their data, about their treatments, their outcomes, and more importantly, their needs. They bring to the table not only the experience of dealing with these patients, these diseases, and these treatments, but also the experience of having tried to do similar research to the one that you go to them with, and there is a lot to be learned from those experiences. And yeah, then they also bring the data, but the data is a byproduct of the effort that these engaged professionals have put to provide better care for their patients and to learn from them and continue the improvement process. And most importantly, they are also a byproduct of the patient's generosity that let us use their data. And that has to always be at the forefront of our engagement. And with that in mind, the work with registries is not based on a transaction. Typically, with the clinical registries, you don't work in a transactional way. And the discussions and negotiations have a lot more to do with achieving a broad consensus than to, negotiate in terms of a transaction. You have to start by choosing the right partner, and that means that you have to establish formalized and transparent criteria, but then remember that these are just a conversation started with the in-depth understanding of each of the registries, create tiers, and of course everybody will want to work with the best. But in the second tier, there is a lot of potential, and that's where one can find a good partner to improve processes and to bring them up to speed. And that's how you have to sit and discuss with them, with that mindset, with a how can we be of help to bring you up to speed. Then when you have identified the right partners, you have to find the right way to cooperate. And there isn't one bulletproof way, because the registries are very different and they vary not only in what they have, but also in terms of expectations, of motivations, of capabilities, and determinants like legal determinants, national frameworks, and so on. And they create overlapping and sometimes contradictory normative frameworks between the national framework and the rules that they give themselves to function. A mosaic of contractual agreements are needed in each case, from data privacy and service and confidentiality and so on. And some of those have to go in parallel, or consulting agreements with the experts and so on. Again, they also have varying capabilities in terms of formalizing all of those expectations and motivations and so on. So you have to work with them to create those tools that enable the discussion. So one has to be extremely flexible, and one has to be creative and be prepared to tailor the collaboration and the value proposition to each potential partner. And once you have identify them and engage them, the work together that is typically long-term also has to be very respectful. And one of the most important things is to remember that not only the registries are your partners, not a vendor, but also their leadership, whether they are called curators or principal investigators or so, are your peers. That means that it's very important to work together in the generation of robust scientific work, and they have to always see that connection with the applications and with the impact to the patients, and so do we. So that's how you start trying to build trust and continue to strengthen that relation, so that even when the study is done, you leave something behind for the community that generated that data. And the other key components is also very long, because when you are defining the data strategy, you have to tailor it to the best of your abilities to the research question and to some of the determinants of each, again, each study, either from the normative framework, the epidemiology of the disease, and so on. So there are a plethora of methods that give us the confidence to find a proper analytic approach given those determinants, and they go from being able to convince the registries to share with you the individual patient level data, so that anonymized, of course, so that you can create a study data set and analyze all the nuances that you need in that study, to the ones where the registries can conduct all the studies and you limit yourselves to harmonize, to guide, to QC, and then to meta-analyze results and so on. In the middle, there are all these federated models with more or less levels of aggregation, some of them more better suited for descriptive type of analysis, others better suited for inferential analysis, but also with different degrees of demands on the technology that has to be created to enable them, on the analytic capabilities of the individual registries, on the advancement of the harmonization methods for the data and so on, and on the type of data themselves, the possibilities of sharing, sometimes individual patient level that is not sensitive or not, and so on. And before finishing, I wanted to share with you a success story that was a success because of the result of all of these other soft, if you will, considerations. We've been working with Roche, that is the sponsor of risdiplam, a treatment for children so far, mainly with spinal muscular atrophy. And they were, there was a post-authorization efficacy study mandated by the EMA. And the interesting thing is that EMA at the same time was mandating a study of their own initiative. And we have been working in this study for more than a year. And well, I'll start by the end. The end is that it's a success story, because we have already delivered the first progress report on time, and that included data from 9 physician-reported registries in 11 countries that contribute, again, individual patient-level data to this central study. And that was a big success. Why? Because this is a rare indication that depended for which the study depends a lot on the possibility of presenting stratified results by a very strong predictor of outcomes that is also confirmed effect modifier. So when you have all of this, and then the groups for the stratified analysis start getting smaller and smaller, there are all sorts of issues with small cell suppression rules and so on, so you cannot deploy the federated analytics, and the IP in the individual patient level data transfer and harmonization is indispensable. So that's what we did, thanks to Roche's generosity as well. We managed to meet them where they were and to find common ground with each of them, and the common ground was the quest for quality, for enhanced quality in all of them. So they accepted to share individual patient level data, and they also get I won't go into the details. There are different models with each of the registries, but some of those quests for enhanced quality had to do with outcome assessment workshop. Others had to do with a full validation exercise. In other cases, we do create and formalize the whole data quality assessment, the data quality assurance plan, and the implementation, as well as the quality controls for them to then take on their own and continue doing, and so on. So basically, the fact that we had complementary roles and that the relevant questions were put at the center of the discussion with the clinicians that also see the need to conduct this study, and the openness to share not only data but also know-how and knowledge, and the mutual aspiration of improving the data and the processes and the practices kind of left us in an even better position than the study that the EMA is conducting, where they are delayed and they didn't manage to engage on the registries and so on. So we're very proud of this one. And now Javier will tell you a bit more about some of the operations and practical issues of working with the registries.
Thank you, Naila. Can you hear me well? My name is Javier Cid, and I'm Senior Research Scientist at Evidera. And I would like to talk about some practical aspects, some details based on our experience, and I hope you will find them useful. Working with registries, we need to take into consideration multiple aspects, multiple details, as Naila has already introduced, and I will touch briefly on several of them as well. As starters, I would like to talk, and I would like to refer to you to these guidelines, to these documents that are coming from regulatory bodies. We're not going to discuss the details. We're not going to go through them. I just want to leave them here as a useful resource. I'm pretty confident several of you are familiar with these guidance and guidelines. If you are, I encourage you to go back and review them, because they are very valuable resources. If you are not, I encourage you to go and use them and refer to them when you need to work with registries. I think they can be useful working with other data sources as well, and they are a nice refresher about aspects to take into consideration. They come, as you can see there, from the EMA, European Medicines Agency, from the FDA, from NICE, the French Health Authority. I didn't go into adding specific details, but you can find also guidance from Health Canada, from Australia, from China, from Brazil, and even from CIOMS that they have sent to us a draft document from the future. that I think was cute and a very valuable resource. Now, my starting question here is, how do we end up interested on registries and registry data? Usually it's because we have a question that we're trying to answer. We want to describe something, or we have a hypothesis, and we believe that using real-world data is the best resource that it will be available to us. And the first step is assess which data sources are available up there. And for certain exposures, the most relevant resource is a registry or several registries. So we start by conducting a landscape feasibility assessment, data source landscape feasibility assessment that chances are is going to provide to us a number of registries that could be candidates to participate on the study that we are planning. It is an important step because we should identify, create a catalog of data sources, do a first triage, and assess which ones would be most suitable, focus, zeroes into those that could be best candidates, do a second triage, and eventually decide which ones are going to be the most suitable, and make a decision and try to collaborate with them, invite them to participate in the study, turn them into research partners. That is something Naila has mentioned, and I want to stress out. It's very important to work with registry and registry custodians as research partners because all of the wealth that they can contribute. And to do that, in our case, we tend to create a study data evaluation grid that is study specific, and it is inspired on similar dimensions as one very relevant resource that I can recommend to you. That is the request tool. You will have more information on the previous slide, where there are 23 dimensions or 23 aspects to take into consideration, maybe for your study. There are a few more that you will need to add. And eventually, all those many dimensions, all those many variables, all those many considerations can be summarized into a go, no-go decision. Allow me to present this slide where I was trying to summarize. We're taking into consideration multiple dimensions and multiple aspects of the registries that we are assessing, or if we find a registry that is good on the size, the number of patients available, the data quality, the timeliness, the methodological capabilities, you name it, it's fantastic. They are willing to participate in a study. It's a no-brainer. Unfortunately, that doesn't normally happen, and that is exceptional. Similarly, if we find that we have identified some registry or some registries where the data is bad, the number of patients, including the registry, is small, they are very slow on any interaction, they don't want to participate on studies that they are not promoting themselves, again, it's a no-brainer. That's not a good candidate to participate in an initiative that we're trying to launch. But most of the time, the situation is somewhere in between. There is a gray zone where we need to embrace limitations, take into consideration good characteristics, good quality, but not as good as we would like in terms of methods or in terms of data. And eventually, we need to decide, can we collaborate? Can we invite? Are we able to engage with this registry and another possibly, or we cannot? And here is where some of the recommendations that are from those guidelines and from everything that we have been taught when we were at the school and everything that we're striving for about excellence hits reality, and we need to decide what to do, and eventually, as sometimes like to say, a famous quote, in theory and practice are the same, but in practice they are not. And what we are trying to do is practice on what is doable and do the best we can with the available resources. I would like to move on and talk about a few considerations. This is not exhaustive. Those of you with experience will have other examples that you could bring here. And in those methods, papers, and guidelines and guidance, you will be able to find more details. These are just a few highlights that I think I can touch briefly on the few minutes that we have. Important item when we are studying, for example, as many of you said, rare diseases. What is the size of the patient population that we're able to accrue and to identify and to accrue data from this registry? Well, is it large enough? Chances are it will not be very large because we're talking about rare diseases. And chances are we will need to engage several of these registries, which is great because that means that there is light at the end of the tunnel and we will be able to obtain as many patients as we're interested in. But that also adds complexity because data comes from multiple registries, possibly in a single registry from multiple countries, and multiple registries, multiple countries. That is an aspect to take into consideration. Is the quality of the data good enough? Chances are it will be good, but possibly we would like it to be even better. And can we manage with what is available? To that end, I think it's important from the get-go to define some key performance indicators that are going to allow us to assess data consistency, accuracy, completeness. That is something that some of you also mentioned as a challenge of working with registries. And try to improve along a study conduct if possible. Is the data complete enough? Do we have a lot of missing data? Over time, data keeps being accrued, or that is also a challenge? That's a relevant element where we're trying to achieve a certain target sample size. How representative are these patients? Because possibly they are representative, say, of a country. But let me give you an example. We have a registry that is from a certain country, but that registry most likely has a reference center where the data flows consistently and regularly and is of good quality. But that center itself gathers data from multiple other centers in the same country. And those other centers might not be as responsive when it comes to providing data, might have different standards in terms of quality, in terms of resources that they're able to devote to contributing to the registry. And we think, because this is the registry of a certain country, that we have a good representation of patients from that country. And it might not be the case if the data is not flowing smoothly and consistently and homogeneously from all centers and from all sides. That is something to consider when we are assessing the registry, when we are assessing the data available, and when we are interpreting the results. Timeliness. That is also something that has come up on your answers, and I'm sure it will come up on your studies and your research, because we tend to be optimistic. We want to have good data on time and recent data. And experience tells us that usually registries are optimistic in terms of the completeness and timeliness of the data they have, and how easily, how rapidly it could be available, or if they are conducting analysis and they are going to provide results, how quickly and how accurately they're going to be able to do it on time to meet certain deadlines. Let's be realistic and let's be supportive. If we are able to provide support to the registries, they are more likely to be able to deliver on time. And another item that is worth mentioning is security in terms of data security, traceability, being able to audit what has been done and how it's been done. There are also technical considerations. Naila has mentioned platforms. There are also ethical considerations we'll touch briefly later on. These are aspects to take into consideration, and we should brace ourselves most likely for a long and winding road, because it's important to do it well, but it's important also to do it in a way that is realistic. I'm not going to touch on all of these items, and I want to just highlight that the road that is ahead of us is bidirectional, in the sense that there are aspects, for example, such as ethical considerations that are going to play a role at the beginning, on the setup, on the startup of a project and a collaboration with a registry or multiple registries, and are going to be especially important along the way and towards the end when it comes to publishing results and be able to comply with all data privacy regulations and legal requirements. Another aspect that I think is important and I would like to highlight is that we all strive for scientific excellence. We all strive for getting as much data as possible and be able to provide as many results as possible. My advice is that we focus on what is specifically important. We need to focus on what are the primary objectives of the study that has a primary motivation. And although it would be nice to have some other material and some other results, those that are nice to have are likely to be destructive, are likely to add complexity. Complexity means more burden to the registry, burden to the patients, burden to the investigators, and they are not going to be so useful at the end. So let's try to be realistic. Let's aim for what is most important. Let's deliver. And later on, there will be opportunities to conduct other studies and pursue other goals. And finally, I just want to mention that when it comes to the end, we will be very happy if along the way we have logged everything that has happened from the very beginning in terms of questions and answers, decisions, everything that has taken place, because being a long-term collaboration, it's important to be able to trace back decisions made along the way. It's important to understand what was decided, why. It's important to provide consistency when there are multiple registries involved. And to that end, also, having a coordinating center is a very valuable resource, a coordinating center where all decisions are kept in a way that are easy to retrieve. And coming to the end doesn't mean that it's the end of the collaboration, because working with a registry, establishing a partnership is a very good starting point for conducting subsequent studies. In fact, registries are a source of data, a source of expertise, as Naila was saying, to develop other studies that are going to be relevant to the patient population, that are going to add information to the science of healthcare and looking after patients. And similarly, think about what if a study, a registry that was set up for a study, does not need to end when the study comes to an end. It can be the starting point of a registry. That is also something that I have experienced. And for example, the Discover study was the starting point of the Discover Global Registry, which I think is a valuable resource. All along the way, I hope you get the hint. There are going to be challenges. And I always tell my colleagues, we're going to find the problems, we're going to classify the problems, and we're going to find solutions for those problems. Possibly, there will not be perfect solutions for all the problems, but we're going to find good solutions as best as we can for the most important problems that are going to allow us to make progress, to be able to obtain valuable results that are going to inform all those use cases that Naila was explaining before. For example, it might be a challenge to obtain individual patient data from some registry. Well, we should be able to work with the results that they provide. In order to do that, we should also be relying on the data that is produced. And to that end, we should be able to provide answers and clarification when there are questions about data management, data curation, and even be able to provide programming so that if we start from a common data model, we have a good data dictionary, we're able to provide all the same programming, for the analysis of the data in multiple registries, that is going to provide us with good results that we can trust. Possibly patients are going to be difficult to engage, but if we support registry activities promoting participation and permanence in the registry, those patients are going to be more willing to participate. There might be gaps on the data, because data that was not so relevant some years ago now is important for the question at hand. Then in that case, we are likely to support that expansion on data by collecting additional data, and you will hear more about it later on, or by linking to other data sources. Data could be heterogeneous, but we will need to take account that heterogeneity and deal with it, be able to interpret what it comes from a heterogeneous set of data, heterogeneous set of results, and be able to use it to our advantage. And for example, I would like to just mention that something that is very hot lately is the idea of informed consent. It is drawing a lot of attention, and that is something to take into consideration, because in an era where we share so much data among ourselves, it's important to comply with regulations, but at the same time, it's important not to allow that for ease opt-out of studies to patients whose data would be valuable for the public health and for the good of the larger collectivity. And I'm sure that we will see a lot of evolution on this topic, and you can contribute to this discussion as well, of course. And I would like just to wrap up with a case study, but I'm not going to go into the details. I just want to highlight that registries are a source of very valuable expertise, very valuable data. I would say they contain gold, but we cannot expect to obtain gold without digging and mining, and that requires effort, but the reward is worthwhile. And as part of the effort that sometimes registries require is collecting additional data, finding data that is not readily available, and about that, Delphine is going to talk to you. Delphine?
Thank you, Javier. Hi, everyone. My name is Delphine Saragoussi. As Javier just said, actually, there's really a possibility to work closely with the registries to address some of the challenges that might have been found out in the exploration. And you might hear the wording registry augmentation, and this might actually mean adding variables or time points for data collection to the existing registry data. I've also seen in your answers to the first question that the data completeness, the data accuracy was a challenge that was coming back often, and that's obviously very important. And it's true that we can do that also, as Javier said. I see in the polling question, yes, the majority of you say discuss with the registry owner and negotiate, and that would be indeed absolutely my recommendation, right? The polling, the answers to the polling questions were a bit caricatural, and of course you want to in this relationship with the registry, work with them as much as you can to make sure they're collecting the right data for you. And it's a negotiation, right? It's also showing the registry what advantage they can have collecting this data. But registry augmentation, it's not only that, it's also working with the registry at, for example, improving their quality control processes. It's all very important, and all the more important since the regulatory authorities have been issuing quality criteria in their guidances. And also from a data access standpoint, and if only it's working with them on the governance. So it's really possible to offer a tailored support to the registries as part of the collaboration. And I have a case study on the next slide. A rare disease registry with whom we worked at actually developing their processes to make the registry fit to support registry-based studies. If we can move to the next slide, please. So that was really interesting, right? These were the administrators of this rare disease registry were aware of some gaps and needed support with upgrading their processes so that they could really become fit. And it was really regarding lots of topics like setting up the governance model with the sponsors, ensuring the data quality, reassuring the sponsors on the collection of safety data. And so that's really, although that's not necessarily what comes first in mind, that's really some support that can be provided and which is really beneficial to all parties. Let's move to the next slide. The last resort is okay, what if there's no existing registry in the space you're working on, or what if there are a few but very disjointed, etc. There's always at the end the option of setting up a registry. There are really circumstances where it makes sense. For example, a rare disease where there's no academic initiative, and that can allow to connect with the patient community and the healthcare providers. And doing that, it's an investment, but it allows to generate natural history data, burden of illness data, and to use a registry for any kind of registry-based studies, including post-marketing commitments. So a registry is like a kind of a big prospective cohort study, right? But on paper, it looks like a streamlined prospective cohort study. But streamlines mean that there need to be some specific operations, and does that especially to limit the patient and site burden and to ensure the retention and the continued data quality over time. So just the next slide is a case study to show that it's not that easy, and it requires a specific mindset to put together registries. This is an example of 3 disease registries and 1 drug registry, which were rescued in terms of reviewing the operations to increase the participation and the recruitment, improve the data quality, and ensure that these registries could really last for the time they were supposed to. Some of them had still 13 years to go. So yeah, this is indeed, I think what Javier was saying about the journey is true. Whichever is the approach. And I'd just like to finish with the next slide with a perspective on the fact that thinking about registries, clinical registries and registry-based studies, it's an entryway into a world where creativity is possible. And especially now with all the different sources of data and the technologies, we don't have to think only about collecting data at sites about the patient, but also about augmenting with other sources of data, extracting data from the electronic medical records to relieve the site from some data extraction burden, including biosample data, collecting patient-reported data, right? That's also something that's often needed and not necessarily part of initial registries. Wearables, of course, are also there, and all that can be designed up front and managed to go into the same EDC platform. But also it's possible to link data from secondary sources in some geographies and some contexts. So this can be kept in mind when thinking about a registry-based studies. It's really depending on your study objectives, your geographies, what's available. Yeah, with all the technologies nowadays, and then the data collection possibilities and data science possibilities, there's really room for creativity. So I'll hand it back to Naila for the conclusion.
Thanks, Delphine. And since we are running a bit short, please feel free to start typing your questions in the questions tab. I just have a couple of wrap-up comments. If we go, I have the. So yeah, we're talking about the registry in this continuum, and to basically summarize what Delphine was referring to, we can, of course, when we work with registry, we can think of that continuum and how much is there, how much can we achieve with what is already ready, and that maybe only needs some quality improvements and so on, and how much more needs to be done. And in that continuum, we go back and forth with the different levels of specificity of the data set that you will obtain, and the different levels of site and patient burden. So to sum up the 5 or 6 bullets, one more slide again, letting I have it. So the clinical registries, as we said, are the embodiment of the entire communities, and that is the source of value, even more so than the data. They are diverse, their complexity and the complexity of the data, the heterogeneity of their methods and of their uses and of the restrictions and so on, can actually be an asset when you're going to work in registry-based studies, because then they can guide the next steps when, especially if everybody's focusing on quality improvements. The most prominent use cases that we describe in terms of both the regulatory and the HTA, as well as the informing clinical development programs, were supplemented by some interesting answers that I read. So thank you so much for that. When one works with registry, one has to be mindful of the need to leave something behind, and therefore support their efforts in many different ways, as we said, throughout that continuum from the previous slide. It's important to continue building upon the expertise they bring to the table, to learn, to contribute to discussion fora, to share, and well, the patients and their needs. I mean, the patient needs evolve, as does the quality and capabilities, as do the quality and capabilities of these registries. So we have to create dynamic and strong connections to maintain win-win long-term collaborations with the clinical registries. So thank you very much for attending. 2 minutes for questions. I don't know, Christina, if you want to.
Okay.
Oh, no,
Thank
Sydney,
you all.
sorry.
Yeah, that's okay. Thank you so much for that wonderful presentation, all of you. So let's answer some questions. In your opinion, which is the direction of travel for these registries? What do you see in terms of future trends?
Yeah, thank you for that question. I think that we touched upon it at the beginning, and I think that there is that trend towards more technification, if you will, or more sophistication of the data collection tools and instruments at the point of care. And there is a whole discussion about where we are going in terms of harmonization. And there are big proponents of OMOP is universal, and there are others who believe that perhaps the OMOP is good for some stuff but not for everything, and some clinical outcomes in different diseases have to remain to be harmonized on a case-by-case basis. In terms of the collaborations, they are expanding in this multi-stakeholder scenario, so I think that they will become richer and richer, if anything, and the uses are also being formalized more and more, and the regulators are expanding those uses. Apologies. And so we will see more of these studies. I don't know, my colleagues, if you want to add.
No, perhaps not. We can move on to the next question. Could you talk about the impact of the study duration in the execution of these registry-based studies?
Yeah, I don't know if anyone wants to answer. I have a few ideas.
I have as well.
Delphine, why don't you start?
I mean, there is the study itself, there's a registry itself, right? The registry is bound to be a rather, long-term endeavor, right? And is expected to be a source of data for lots of things. And then the study duration itself, it adds to that, and it's really the duration where you need to achieve specific objectives. But I think for me, this relates to what I was saying about ensuring a continuous, retention of patients and data quality. So it's really about ensuring the registry has the capabilities, or supporting them in making sure that along the duration of the study, but if possible even beyond, they can really achieve this steady operations. To make sure the right data with the right quality is collected.
I will say that duration is a challenge because it requires that the study is conducted over a longer period of time. It's going to require more resources, more people involved. But it's also an opportunity because it's an opportunity to include more patients, to be able to improve on the details, and it can be used to the advantage of being able to answer the questions that are asked at the beginning.
Yeah.
Okay. Wonderful. All right. Yeah, we've passed the top of the hour a little bit, but it was such a great presentation, very detailed. I want to thank all three of you for being here with us and for providing your expertise and insights.
Thank you for the moderation, and thanks to all the attendees for your time and attention.
In closing, we hope you enjoyed this HealthEconomics.com webinar sponsored by Evidera, and I hope that you enjoy the rest of your day.